Today, we're going to be talking about surgical procedures, the med-surg area. And again, this is the largest part of PCS. So we're going to break it down even more. I know that what we've talked about in the last two lectures has been kind of opening up PCS for us, but now we're going to focus on med-surg alone, and not only the root operations, but specifically some of the other codes, the values and codes in there that we need to work on. Okay, let's see here. First thing we're going to do is talk about those principal procedures. We have to have those under our hat. Significant procedures that are done. We're also going to talk about what do we do for canceled, converted, open, and bilateral procedures. Remember when I said that one of the reasons inpatient was a little harder to get into was because of the dollar amounts that we're dealing with? Absolutely, that's complicated. But in outpatient, when you have something that's canceled or changed up, it's pretty straightforward. But for inpatient, it's not. And we want to make sure that you're being reimbursed. The facility and the provider is being reimbursed at the maximum amount that they're allowed. And if we don't get that coded, the whole story told with that code, then we can lose out on reimbursement. Purpose of facility policies versus procedure codings. And I think I might have mentioned this as well as we were going along, that, it's one thing to know the guidelines and understand them inside and out, not just for PCS, but for all of the code sets that we deal with as coders. But we code for statistical purposes, right? Everybody's like going, yeah, I can hear you say this. It's a convenient way to get paid. Now, this is where if we have a facility policy, it usually is based on something to do with reimbursement, okay? And do facility policies trump, coding guidelines? In some incidences that you'll see that there is a little bit of gray area, and you don't need to panic, because if it is, you're protected if it's a facility policy, right? Now we're getting into compliance, that it might be gray and they're not sure how they want, to do it. So all the experts come together and make a decision, say, this is the way we're going to do it, in their compliance program. And then going forward, there's a reason why. And you sometimes may not know the reason why. So again, we'll talk about that a little bit. So principal procedure with PCS, that is the first code. That is what we're doing to the patient. And we have talked about principal diagnosis, and that principal diagnosis is actually how we're getting reimbursed. But the procedure in inpatient has to back up that diagnosis. It explains, right? It tells the whole picture. So the way we select that principal diagnosis is based on DRGs often, and we discussed that. But with principal procedure, that's got to follow that main reason why the patient's being seen or held in the facility. Can we have more than one procedure going on? Absolutely, we can. So sequencing is going to be important. What is going to meet the criteria when we say it's a significant procedure? Well, there's a few things that we need to keep in mind. Is it surgical? Are we going to go in and do use anesthesia? Are we completely putting them under? Are we opening up the patient, et cetera, et cetera? Think of what constitutes as a surgical procedure. And that's not only what we do. Sometimes we do manipulation, right? Where we don't actually, go into the body. It's still surgical. Does it carry a risk? Is there a risk in anesthesia? Now this, if you are familiar with anesthesia, sometimes, extreme age can can carry a risk with anesthesia. And does it require specialized training? So do we need an orthopedist in there? Do we need a cardiologist, a neurologist, right? It's not general surgery. So that would classify it as a significant procedure if we can answer any of those questions. And I would take a time to write that down, those 4 components. We have our principal procedure, and then we have significant procedures that could be done. Can a patient have more than one significant procedure? Absolutely. They could have a return to the OR. They could have, remember our Mr. Green that we've been talking about, pneumonia, as well as, having that infectious foot ulcer that we keep referring to. What are some of the procedures that could be done with pneumonia? Well, if they're just going to put a drainage tube into the lung, that's not necessarily a high risk for anesthesia. They can do that at the bed. They don't have to take it to the OR. But there's other things that they can do. So in the past, and you may have heard me talk about my son, who when he was young, he got a unique type of pneumonia that was inside and outside his lung. It was inside the pleural sac, though, of the lung, and it deflated the lung. It collapsed the lung. And, they put drainage tube and everything in there, but ultimately what they had to do is surgically open him up. He's got a big smiley face under his arm, and scrape the infection off the lung. Now that is a significant procedure that isn't necessarily always attributed to pneumonia, right? That the lung collapsed, and sometimes they can just put a drain tube in, and it releases the substance that's collapsing the lung, and the lung opens back up. But in this incident, it didn't happen. It wasn't working, so they had to actually physically go in. Significant procedure. It was surgical in nature. It did carry a risk. It did carry an anesthesia risk because he only had one lung that was working. So his airway, his breathing was compromised, and it required special training. So a pulmonologist was involved in that. Plus he was in the pediatric. Now that was an extreme age, because I think he was 9, I think, when that happened. But still, we always think of anything happening to children. So not only was he had a pulmonary specialist, but he also had a pediatric specialist involved. When we do talk about the procedures that are being done in inpatient setting, it does affect the reimbursement. Now, reimbursement is based on our diagnosis codes with inpatient, okay? But it's different than outpatient, because with outpatient, you're reimbursed for the E&M, you're reimbursed for any procedures that you do in the office for the patient. Maybe we're going to suture a laceration, we're going to place a cast, we're going to debride a wound, things like that. Those are what you're getting paid for. And the diagnosis backs up and says this, our patient has diabetes and a wound on the foot that needs to be debrided and cleaned up because of their diabetes with this manifestation. Okay, but it's the procedure that's causing the reimbursement, not the diabetes, whereas it's flipped with inpatient. So that same patient, we're being reimbursed for the fact, a lump sum for the fact that they have diabetes with a foot manifestation. Okay, so you get a lump sum. All of the procedures that are commonly associated to having that diagnosis is assumed is probably not the right word, but it's factored in. Okay, so let's make up a number. Say that it's going to cost $10,000 to take care of a foot ulcer for a patient that has diabetes, and so that's our diagnosis, $10,000. Everything that happens to that patient, all of the procedures that happens to that patient is covered under that $10,000, because that's how much money is reimbursed to them for that, for the facility. So if more is done than the 10,000 covers, then we better have some other diagnoses to explain why those procedures were being done, because it does affect the reimbursement. Well, one example would be our Mr. Green that has the diabetic foot ulcer, but he also has pneumonia, right? So is that going to affect his ability to heal? Probably, because his oxygen is compromised, right? And he's already got an infection in the body, and now he has 2 infections in the body because we have an infected foot ulcer. What's the reimbursement going to change? Well, we got to make sure that it doesn't become septic. And then we were, adding to the story and saying, oh, it developed gangrene. Well, now we're looking at amputation. So gangrene just made this 10,000 reimbursement jump to 50 because we're going to have to end up amputating, right? So the procedures do affect payment or reimbursement because they tell the story. We've got to capture all the diagnoses, though. There are procedures that are done according to a facility policy, and that is because they know how much money is set aside for a specific diagnosis, right? You are going to have to absolutely match up the procedure codes with the diagnosis codes. If they don't match, it's not going to make any sense to your payer. And they're going to say, well, how come, it costs $50,000 to take care of this patient with a foot ulcer? Well, because he was diabetic. Oh, okay. Well, that's $10,000 normally. So why did it cost more? Oh, well, because he had gangrene. We've got to match that up. We've got to link that up. And we have to show medical necessity all the time. With outpatient, medical necessity is shown with the diagnosis code, right? Why would we have our patient going to a podiatrist, a specialist? Because he's diabetic and he's had foot issues in the past. That's medical necessity. That's why we would be having him go to a specialist, a podiatrist. Why in the inpatient would we show medical necessity? Well, medical necessity of amputating a toe because of gangrene, right? We're not going to amputate the toe if we think that we can fix the toe. If it's an infection and it's okay, we don't need to amputate. That's not medically necessary. But if there's gangrene, you amputate. You can't cure gangrene in a diabetic toe. So medical necessity has to be there. Everything has to line up. And that means as an inpatient coder, you're really looking at a broader sense of documentation. Another reason why new coders tend to not be put in those positions right away. That now, don't get discouraged, because if this is your first credential and you think, why am I doing this then? No, don't worry. You'll be trained to do this, but you'll get better. So they would hire you, but they would start you maybe in individual or certain areas of the facility and not get you in, you're not going to be coding heart transplants right away, things like that. So again, this is a great credential to have. And you see why the understanding of procedures, diagnoses, and the disease process is so important with inpatient. Valid OR procedures. Well, again, we have to have medical necessity for it to be a valid OR procedure. This is going to affect our DRGs, and that is what constitutes our reimbursement. The DRG says, that we're getting paid $10,000 for a diabetic patient with a foot ulcer, and we're getting paid $50,000 for a diabetic patient with a foot ulcer and gangrene. Okay, that's how the DRGs kind of do that when you break it down to the simplest, but sometimes you're not going to have the procedures performed in an inpatient setting. Okay, you could actually do them as an outpatient. Now, what would be a procedure that could be done outpatient? A colonoscopy. easily done as outpatient. So think of your surgical suites and you've got these surgery centers popping up and stuff, that they specialize in one particular area, getting preventative medicine done, colonoscopies and mammograms, things like that, right? So you have to be able to show the medical necessity that this was needed to be done in an inpatient setting versus an outpatient. What happens when we have procedures that aren't covered? Well, Medicare, as the largest payer out there, tends to be the lead in this. And because they're the largest, they're the ones that are dealing with the most money paying out. And whatever policies that they set forth or whatever Medicare does, everybody else tends to follow suit. Not always right away, but whatever Medicare sets as a policy or isn't going to cover, a lot of times Medicaid isn't going to cover, and your commercial insurances, they sometimes will, because they're making more money than your Medicare and Medicaid. However, they tend to eventually fall in line with what Medicare does. If it's not medically necessary, it's not going to be covered. So if a person has a rhinoplasty done because they have a deviated septum and it's constricting their airway and also causing recurrent sinus infections and stuff like that, it would be medically necessary. But if a person is having a rhinoplasty done because they don't like the shape of their nose, that's not medical necessary. And there has to be a diagnosis code to show that there's medical necessity to have that rhinoplasty done. And something that could be done outpatient may not be covered. Now, it's covered outpatient, but not inpatient. Medicare doesn't cover everything. Surprise, surprise. There's some things that used to be covered in Medicare that isn't covered anymore, like consultations. There's some things that were never covered before that are covered now. I think of gastric surgeries, gastric bypass, gastric sleeve. In the past, that was never covered. However, they know now that it's more cost effective for somebody that has morbid obesity, especially at a younger age, to have the gastric surgery that stops diabetes, stops heart disease, stops, all kinds of these conditions early on, and your patient gets healthy, and then in the long run they don't have to pay as much. So again, Medicare actually covers some of these, and so does Medicaid, gastric surgeries. You could have limited coverage. Well, when you have limited coverage, then don't forget, you have to understand how an ABN works, advanced beneficiary notice. But limited coverage just simply means sometimes it's covered and sometimes it's not. It just depends. Now, we're talking about commercial insurance as well as Medicare, Medicaid, right? Medical necessity really is the driving force here. Just because, as a general rule, rhinoplasty isn't covered doesn't mean that in certain incidences you can't fight to have it covered, showing the medical necessity. Guidelines usually need to be met before a procedure can be done. So that's why you'll see some diagnostic tests and monitoring done that, if the provider says, okay, I know we need to replace your knee. However, you're on Medicare and they're going to require that first we do injections and then we do all these other treatments. And if they don't work after a specific amount of time, then they'll pay to have your knee replaced. They're not just going to take my word for it that I think that you need to have your knee replaced. They're going to make us go through these steps. Okay. That's why you don't get an MRI first when you go in to have something done. They'll do a chest x-ray, then they might do a CAT scan, and then they do an MRI, right? Because guidelines, there's protocol involved. They want to make sure that you're not just automatically billing us for MRIs because you don't want to waste your time with having a CT done. There are guidelines in the Federal Register if you want to go look those up. It's not required, but Google that Federal Register and kind of familiarize yourself with that. Often you're going to see written policies. You may be even involved in coming up with some of these written policies as a coding specialist inpatient. So these are what actually would be involved with this. Well, we're going to collect data, right? And we're going to match up the statistics, internal statistics. Again, that's why we code. But of course, we're reporting to who, and we want to know globally as well as, not just the internationally, but for the United States and the data so that policies can be put in place. But for the in-house facility, you may want to be collecting this data. How many heart procedures are being done? Can we justify hiring another cardiologist? Can we justify because of the heart disease in our area, adding a wing to the facility for cardiology? What would be the most beneficial demographically for our area? Let's do some data collection here. Will we get reimbursed enough if we add a cardiology specialty group? Or research, we have to research to see if it's going to be cost effective. Can we get the physicians here to be able to qualify as a cardiology specialist facility? And then we're going to analyze that data. It's not something that happens overnight. One of the hospitals that I worked with, the only thing preventing them getting to that next stage for this little hospital for their ER was the fact that they didn't have a neurologist on staff. That's the only thing they needed, and they had everything else in place, and they could get to that. As a trauma center, one of the top trauma centers listed, but they didn't have a neurologist. Well, this was more or less a small rural hospital, but it was a resort area, right? And so they were able to bring in these providers, these specialists that were willing to come and live there and work at this facility. So they had everything else in place, but they didn't have a neurologist. That was the only thing that prevented them. And so again, getting the credentialing and the profiles, the right providers to be there and maintaining that is going to be important. You're going to also look for valid procedures. That means we have to review the entire record when we do that. We're not just looking at encounter to encounter like we do an outpatient every time the patient comes in to be seen. Now, when you do risk adjustment, you're looking at a year's worth of documentation retrospectively for a patient, and it could be inpatient and outpatient, but you get to see that individual encounters. The patient comes in for their well clinic. The patient comes in for their flu shot. The patient comes in because they have an upper respiratory infection, a UTI. He thinks he broke his toe. The patient comes in to, and you see this all being done in the outpatient. The patient comes in because they have pneumonia, and then they get placed inpatient, things like that. Documentation is going to be something that drives the inpatient coder. You will end up being a document specialist. Risk adjustment, you end up being a document specialist because you're looking at all of this varied documentation from inpatient to outpatient. Now, you're not coding it like an inpatient coder does or an outpatient coder or even a specialty coder. You're looking at everything in risk adjustment, right? And only abstracting those chronic conditions. Whereas if you're in a facility inpatient coder, you're coding everything, right? For that length of stay till discharge. And documentation for the inpatient coder, when we want to do set up policies, we've got to dig through every nuance of that patient's encounter, whether they're in for 24, 48 hours, or they're there for, 2 weeks, right? And think of all of the documentation that's involved for a patient that is in the hospital for 2 weeks. That's a long time. Now let's step back and talk about bilateral procedures. It's easy to miss some stuff with bilateral procedures. Now, for the most part, we understand bilaterality in the body. We have 2 lungs, we have 2 eyes, we have 2 ears, we have 2 knees, we have 2 hands, feet, we have 2 upper extremities, 2 lower extremities, and things like that. If you're doing a procedure and we are going to do the same procedure bilaterally, then how do we code that? Now, there is laterality is not built into PCS the same way it's built in to CPT, because with CPT, if you're familiar with that, you can just add, if it's not in the code description, we can just add a modifier. We can't do that with PCS, so it's a little bit different. We need to think about not just outside the body, but we need to think of organs and tissues inside the body as well. If we do a single procedure and we do it on a body part that has laterality, we have to ask ourselves, if we don't have a bilateral body part, then we can easily code that procedure, but we may have to code each procedure separately if there isn't a bilateral code involved there. Closed surgical procedures that end up being open procedures. Do you remember I told you about when I had my gallbladder taken out and the surgeon kind of prided himself when he came and he talked to me before we went into the OR suite, and he said, I do my gallbladder removals laparoscopically. Very rarely do I have to go ahead and open you up to take your gallbladder out. But if I do, and I'll put it off, I don't want to have to do that because your recovery time's longer. If I have to, though, know that I do that as a last result. Okay, that which was reassuring. And then when he got in there, and I did have it laparoscopically done, but when he came back and visited me, and he said, I almost had to open you up and change it to an open procedure, because he said my gallbladder issue was acute, and it just kind of like rotted or got real slimy and bad right away. And he said, I kept trying to get it out. He goes, and I couldn't. He goes, I couldn't get it. And he said, I tried, 4th time, but the 3rd time I said, if I don't get it this 4th time, I'm going to go ahead and open you up and do it. And he said, and I got it. So that was good. But he said that doesn't happen very often. So what happens if that had gone from a laparoscopic procedure, which would be considered closed, to an open procedure? Well, it starts out closed, and we do laparoscopic of the abdomen. Then we might have thoracoscopic of the thoracic area, and arthroscopic for joints. Those are all closed procedures. But there are incidences when they have to be converted to open. They become open. Then we need to know why they were converted. We have to have medical necessity, and that's going to have to be coded as well. So if you have a laparoscopic procedure and you convert it to an open, you're going to actually code 2 codes, because you get to code an inspection as laparoscopic approach, but then we get to code the open procedure. Isn't that great? We get to assign 2 codes. The laparoscopic, because we got in there and we looked around, they get to be reimbursed for that. And then the open procedure for the work that's done for actually opening the person up. Whereas in CPT codes, you just use the 1 code for the open procedure, and the laparoscopic is included in that. Not like that with outpatient or with inpatient. So other things that can happen could be planned or canceled procedures. If we plan a procedure and it ends up not being done, what do we do? Sometimes you don't have a record of that, but we need to make sure that that's all documented properly. If you do have a cancellation, then is it because of a complication? Did our patient, develop a high blood pressure at the last minute? And the anesthesiologist said, no, we can't go through with this. Or did they actually get them into the OR suite and the patients started anesthesia and their blood pressure bottomed out or whatever, and they said, no, we can't do the procedure. Maybe they got in there and started the procedure and see a mass that's going to change what they decided to do originally. So was it a complication, the reason that it was canceled? We need to know the reason why it was canceled. We would code for the mass, right? That would tell us, that would explain what's going on. You could have secondary diagnoses for clinical reasons that you canceled it, followed by the Z for cancellation. Also, we could have the incomplete procedure. So they went in and they started to do the procedure, and then they discovered this mass that was going to make it more complicated than they thought. So they had to back out and rethink what they were ultimately going to do. So the patient has anesthesia. They're already under. They started the procedure. They opened them up, and then they, what do we do? Well, you code as if the procedure was completed, and then they're going to either reschedule or make statements in the documentation as to what happened. Okay, and often, again, it's that diagnosis that's going to carry the weight, that explains, was it a complication? Was it a was it a mass that they found? What happens when we need to do biopsies? Well, if we do a biopsy, then there's 3 root operations that we're going to fall under. We're either going to do an excision, extraction, or a drainage. That's because we're obtaining something from the body. Remember, with a drainage, it could be liquid or gas, right? With extraction and excision, you need to go back and focus. These are outcomes. Root operations are outcomes. So what's the outcome of a drainage? Letting something drain from the body. So of course it can only be a liquid or a gas, right? We're not going to take a piece of tissue isn't drained from the body. No, it's an excision or an extraction. That med-surg area of PCS is the largest area, and probably the area that you'll get to know the best, because it's going to be most often where you'll be coding. The guidelines, we've already started going over those and reviewing those. It's really important that you understand the procedures that are being done. I would advise you to go in and look at procedures on websites like OR Live, and YouTube is a great place again, but there's a lot of physician training specialty websites that for orthopedics, ophthalmology, where you can see them actually go in and replace the lens in the eye. Maybe it's something simple as a tubal ligation, gastric bypass, knee replacement. Go and watch these procedures being performed. If you have a weak stomach, it's not always the easiest to do, but it gives you a better understanding of what is being done in that procedure. And therefore, it'll make you have the ability to code at a higher specificity, your knowledge, increasing your knowledge that way. There's various approaches. And so when you see them go in and remove a gallbladder laparoscopically, that's stuck in your brain and you're saying, okay, I get it. I see why it's considered a closed procedure, because all we're really doing is poking holes in the body, right? And we're going to just make a little hole and pull that gallbladder out of the hole, versus an open procedure. We're making an incision and we're, really getting our hands down in there, right? It really is important that when you review this documentation, when you read it, that you don't accidentally overlook something, like a procedure being started as open and ended up being, started out as closed and end up being open. That because the documentation at the beginning may say, this was a laparoscopic procedure, and then you see that there was a complication and they opened them up. And then that's going to change the way that it's coded. An example that they give you is look at an op report for a left hip uncemented hemiarthroplasty. So go out and Google that. Even go to YouTube and watch that being done. That would be a great thing to do. Okay, so let's look at the root operations now. I told you when we first started doing the PCS how important root operations were. Once you understand the root operations, and there's in med surg there's like 30, 31, I can't remember how many there actually is, and by the time you watch this there may be more, right? Okay, right now it says there's 31 root operations. Can they remove, they could add more root operations at any time. Every year they're making little nuances, changes. This truly is the most important part of the code when you're building your code. It's pretty easy to know that you're in med surg, and that's always an O. How easy is that, right? It's pretty easy to understand that you're going to be in obstetrics. Or chiropractic. That first character is easy. The second character also is really easy because it's what body system are we? Are we in the respiratory system? Are we going to be working on the brain? That's easy. But the root operation, what's the outcome of the procedure that's being done? Are we draining something? Are we excising something? Are we doing an extraction? We have to know what the difference between an extraction and an excision is, because they kind of overlap each other in CPT, but they don't in PCS. And once you know those root operations, you're golden. Really, PCS is so easy after that. 9 categories. Now, when we've already talked about these a little bit, we're going to talk about them a little more today. And the definitions of these are in your manual, so you don't have to have these memorized. You just need to be aware of them. So in med surg, what can we do for procedures? Well, there's 9 things ultimately that we can have an outcome for, and they're listed here. We can remove something, but notice the detail. If we remove something, we can remove some or all of a body part. That would be a list of, there would be a list under that, these categories. Okay, so there's going to be root operations that fall under these categories. So think to myself, I'm going to remove something. Are we removing all of a body part? Yes, we're going to take out a lung. Okay. Then it's going to be in that category. We're going to think there's going to be a list of root operations there that is there. Okay, but what if we remove something, but it's a solid fluid or gas? Let's say it's not some or all of a body part. It's actually a fluid that's built up in the body. So we need to put in a drain tube. See how that category is different? They're both removing something, but are we removing some or all of a body part, or are we removing something from a body part? Key. The root operations that are in that second category are not going to be the same root operations that are in that first category. The words the root operations may overlap in some of these, but we have to remember, what are we actually doing? What's the outcome? Are we cutting or separating only? right? So we're going to cut something or we're going to separate something. Are we separating a tendon? Are we separating a fascia from there's adhesions in the abdomen, and we need to cut and separate those adhesions because they're causing pain and twisting up the digestive tract. Next, are we going to put in or put back? Okay, put in or put back. So if we put something in or we put back something that was taken out, or are we going to move some or all of a body part? Now, if we're going to move some of a body part, what could we move? We could take the saphenous vein from the leg and move it to the heart in heart bypass. Right? So think of the root operations that could be in that category. We're going to alter a diameter or route of a tubular body part. Now, if we alter it, that's not the same as taking the saphenous vein from the leg. Now, that's a tubular, it's vascular, right? It's a tube, and putting it in, grafting it into the heart for a bypass. That's not the same because we're altering the route. We could take the mammary vessel off of the heart and reroute that. We're not removing it. We're just taking one end of it and putting it to another part of the heart to vascularize and get oxygen to that part that's occluded. Okay, that's altering the route, right? That's not the same as moving the venous vein to the heart, although they both are bypass surgeries. Okay, let's see, something that always involves a device. So if we're going to put in a pacemaker, well, that's always going to involve a device, right? So all of the root operations that could fall under that. Only examining. So we're doing an examination of the ear, the inner ear, because there is deafness and we need to go and do a procedure. So we need to map out, we need to do an exam only. Something that includes other repairs and includes other objectives. Now those, again, we talked about these the other day or in the previous lecture. We alluded to them, but so this is a reminder of all of those. There's 9 categories for med surg. Not starting with a 1 or 2 or 3 or whatever. These are the categories just for med surg. So there's 9 of them. And in those 9, we're going to have root operations that are exclusive to all these involving a device. Now, can we excise a device, or can some of these root operations be used in multiple of these categories? Absolutely, they can. Right? But these are the 9 things that we end up being able to do as procedures. All right, now let's break that down. Let's take that first one. We're going to remove some or all of a body part. What are the root operations that we can use in that? Well, we can do a destruction, a detachment, excision, extraction, or resection. Now we need to define each of those, right? And with a destruction, what are we doing if we destroy something? It's the physical eradication of a body part. It has to be a body part by direct use of energy. All right. So we're doing a destruction. What is our key elements that we have to have in the procedure for it to constitute a destruction? It has to be on a body part, and we have to use some form of energy. Can we use a laser? Yes, we can. Can we use cryotherapy? Something that gets really, really cold? Yes. All right. Let's look at detachment. Detachment, we can remove some or all of a body part in a detachment, but it's only amputations. Nothing else can be used for a detachment. And on top of that, it has to be all or a part of a upper or lower extremity. So if we remove the eyeball, if we, detach the eye, we like amputate the eye from the body, it is not a detachment because it's not an upper or lower extremity. If we remove the ear, the outer ear, is that a detachment? No, because it's not an upper or lower extremity. See how these are so well defined? Okay. If you don't understand that, then you're going to slip up. So whenever a detachment is used as a root operation, the definition of a detachment means we're taking all of or are apart, but it has to be exclusive to upper and lower extremity. Okay. If I remove the thumb, if I amputate the thumb, is that a detachment? Yes, because this is your arm is part of the upper extremity. If I do a BKA, is that? Yes, because that's a lower extremity below the knee amputation. If I amputate the nose, oops, sorry, I didn't mean to hit my mic. If I amputate the nose, no, because it's not part of the upper or lower extremity. It has to be the arms or the legs, or it's not a detachment, amputation. Excision, were removal of a portion of a body part. Now, key, what's the key in that definition? A portion of a body part. So you think, oh, well, I'm removing the thumb. That's a portion of the hand. No, because that would be an amputation and a detachment because it is part of the upper and lower extremity. Okay. If we're removing the ear, that's a portion of a body part. Got it. If we're removing the tip of the nose because there is a skin cancer right here, that's an excision. Right. So what's the difference between an excision and an extraction? So the person has a skin cancer here. They have a squamous cell carcinoma right here on the nose because they were a farmer, right? They're always out in the sun. It happens on their ears a lot. Are we going to excise or are we doing an extraction? We're excising that. We're not taking the whole nose. We're taking a piece of the nose, a portion of a body part, not the whole nose. And we're removing a portion. So an extraction, how is that different? Well, we're using force and we're going to pull or strip out a portion of the body part. So if we remove the saphenous vein from the leg, what are we doing? We're extracting. We're stripping out the saphenous vein by force. Okay. A resection, we're taking all of a body part. So what's the difference between an excision and a resection? The amount of the body part that you're removing. Okay. We're taking all of a body part is being removed. We're removing the entire nose, right? We're taking all of the teeth. We're removing all of the teeth. We're taking the whole lower mandible because of bone cancer, right? If we remove a portion of the cranium, then we're excising that bone. We're not taking the full cranium, which I guess you can't really excise. When you look at bones, it's a little bit different. What are the root operations that go in that second category? We're going to remove a solid fluid or gas from a body part. So we can drainage, we can do drainage, extirpation, and fragmentation. Because remember fragmentation, I said if you got a kidney stone, they can do the lithotripsy because they break a solid matter into pieces. What are other reasons you might do a fragmentation? Think of that. Write it in your notebook. Drainage, we're going to let out fluids or gases. Whenever a person has a major surgery where you're traumatizing the body, your body sends fluids to that area to help with inflammation and the trauma and white blood cells, platelets. And so we need to allow that to drain so it doesn't become stagnant in there and abscess. Whenever you have a mastectomy, drainage is put in there. If you have abdominoplasty, then drainage tube is put there. We've traumatized that body. Think about when you just take the hide off, when you skin your knee, you know how it gets that fluid, it stops bleeding, but it keeps weeping. Your whole body does that inside whenever trauma is involved. Okay, and at a much larger level, we have to allow that to drain off. And so we're letting out a fluid or a gas. It has to be a fluid or a gas. Extirpation is we're taking out solid matter. All right, so we're and a fragmentation is like an extirpation, but we're actually taking out pieces. We're breaking it up into pieces, and then we're doing an extirpation of those pieces. Let's see if we're doing always involving cutting or separation. 2, pretty easy, division and release. If we're doing a division, the definition, what are the key things? For division, we're cutting into a body part, okay, that's easy enough, without drawing fluid or gases, so fluid and gases are not involved here, to separate or transect a body part. Would that be a, let's see, we're cutting into a body part without draining to separate or transect a body part. I think that would be removing an appendix, right? What about a release? We're freeing a body part from an abnormal physical constraint, and that's the key, abnormal physical constraint by means of cutting or use of force. Okay, if you're going to do carpal tunnel, is that a division or a release? Well, it's actually a release because abnormal physical constraint, the reason that carpal tunnel becomes an issue is that in that tunnel, it gets inflamed and the tendons and the ligaments are inflamed and they become abnormally constrained where you can't hold and do things anymore. So they release it. What are the things that we can do when we put in, put back, or move some or all of a body part? Reattachment, reposition, transfer, or transplantation. Okay, so if we're going to reattach something, you only use for completely severed body parts. So my thumb was amputated. Okay, I'm going to reattach it. They're going to reattach it to my hand. All right, simple. It's the whole body part, the whole thumb. Okay, reposition. So I'm only taking a portion of the body part to its part of its normal location or other suitable location. So this would be moving all or a portion of a body part to its normal location or other suitable location. We've had a trauma and we need to reposition the bone. Transfer, we're moving all or a portion of the body part, okay, just like in reposition, to another location to take over the function of all or portion. So this is where you get into skin transfer. So I'm going to take a piece of skin from the abdomen and I'm going to place it on the wound that was created and we're going to transfer it to the big hole we created when we did the squamous cell carcinoma removal. Okay, so I'm moving not all of the skin, but I'm taking a portion of the skin from the abdomen and I'm relocating it to perform a function as skin for another body part. Transplantation, you're putting in all or a portion. So again, that's kind of the same, but we're not moving, we're putting in from a donor. It could be a person or an animal, and it takes the place and function of a similar body part. So a pig valve would be, that would work. Would an artificial Can we use a artificial valve in the heart? Would it be a transplantation? No, because it's not from a person or animal. Ooh, that's close. But we think about that, right? It has to be from a donor, person or animal, transplant. So when we put in that artificial valve, it's not a transplant. If we put in an artificial heart, is that a transplant? Nope, because it didn't come from a person or an animal. Very specific. You can use transplantation qualifiers, which would be allogenic, synogenic, and zooplastic. You have to know what those are. Root operations, if we're going to alter the diameter route of a tubular body part. Now, when we are going to alter that, I think of blood vessels a lot, but it's not always blood vessels. We just have to remember it's tubular. So your intestines are tubular. All of your blood vessels, artery and veins, are tubular. Your let's think of some others. Your esophagus is tubular, right? So if we're going to bypass, well, we think of the heart. We're going to bypass the mammary gland to another location of the heart. We're altering the route of that tubular. We didn't take it out, like the venous vein. We just bypassed it. We moved. Dilation. So we need to make it bigger. We need to go in and do a cardiac cath, open that up. We're going to do an occlusion. We need to clamp it down. Or an occlusion is completely closing off the orifice. So if we go in and we have a tubal ligation and we put in clamps, we're completely occluding the fallopian tubes. If we do a restriction, that means we're partially closing. Okay, that could happen if we have some type of an aneurysm. Right? We're going to partially occlude that orifice. What type of root operations that always involve a device? We can change, insert, or do a replacement. So what is the definition of each of these? If we change, then we're taking a device off or out of a body part, right? And putting back something. It has to be identical or similar device, but here's the key: without cutting or puncturing the skin or mucosous membrane. So if we put in a new pacemaker, would that be a change? No, because we have to cut into the skin to pull that pacemaker out of the pocket and put another one in. So it cannot be a change. What about insertion? Well, let's see. It's got to be a non-biological device. We don't insert anything into the body under this category, under this root operation, that isn't a non-biological device. And what does it do? It's got to monitor, assist, or perform, or it could prevent physiological functions, but does not physically take the place of the body part. So we're interrupting something, we're changing something, we're monitoring something, but it has to be a non-biological device. So it can't be inserted from another body part, and it cannot take the place of the body part, right? It can't physically take the place of the body part, but it assists, it could monitor, we could put in leads into the heart to monitor the function. That'd be an insertion. We would not do a artificial heart because that takes the place of the body part. That takes the place of the heart. So that wouldn't be an insertion. Replacement. Are we putting in or on a biological synthetic material to physically take the place or function of all or a part of a body part? That's a heart replacement. Synthetic heart replacement. Okay. Artificial heart. We didn't use one from a donor. It was artificial. So it's not an insertion, it's a replacement. Notice the key things that make these different. Now, these are all in your manual, in your PCA manual. So you want to make yourself notes where it lists these, and just off to the side, like say, okay, this would be a heart transplant. This would be a carpal tunnel. This would be taking the venous vein. This would be moving the mammary artery in the heart. Okay. And if you don't know how these are done, you need to go look at the procedures so that you can understand why it's a transfer versus a bypass. So we're root operations continuing that always does a device if we remove something. So we're taking a device off or out of a body part. That's all. We're removing the pacemaker. A revision, we're correcting something, okay? And it could be a malfunctioning or displaced device. So let's say we're not removing the pacemaker, but the pacemaker has slipped and moved and is causing pain for that body. So we're going to do a revision. We're going to go tuck that pocket up and change it. We can also do a supplement. So that's putting in or on, and it can be biological or synthetic material that reinforces or augments the function of a portion of a body part. Doesn't augment the whole body part, a portion of the body part, or reinforces it. So we're putting something in that physically reinforces, like a stent. Right? We're inserting a stent that it's synthetic, and it's going to reinforce that tubular artery. If we're just doing examinations, there's only two. We'll either do an inspection or we're going to map something. So inspection, we're just physically looking at the body, okay, or mapping something. Now, this note, it says limited to CNS, cardiac conduction, CNS, central nervous system, or cardiac conduction mechanisms. You can map. There are only 2 tables, and it O, because we're in med surg, and then OK or O2K. So go look at those. Make a note and go look at what we can do in mapping in the tables that are involved. It's pretty limited. The more limited you are with the description, the easier it is to find the proper root operation. Whenever we do anything that involves a repair, then we can either control or repair something. If we're controlling something, we're going to stop, or notice it says attempting to stop, because sometimes it doesn't work. You know, we're attempting to stop a post-procedure or acute bleeding. That's what that means. So we're stopping that post-procedural or acute bleeding. We're putting on a tourniquet. And again, we're attempting to do it. So it's either stopping or attempting to do it. And it always has to do with something post-procedural or acute bleeding. So if a person has blood in their stools due to a gastric ulcer that's hemorrhaging, is that going to be under control? No, because it's not acute bleeding. That's something that's kind of chronic that goes on for a long time. Repair. A repair means we're trying to get it back to the way it was. And sometimes we're not able to do it completely, but that's why it says to the extent possible, because sometimes we can't completely repair something. And it can be a body part to its normal anatomical structure or function, right? So if we're going to suture skin, right, we're going to pull it back together to get it back to its normal function, which is to protect everything under the skin. Other objectives, we can do an alteration, we can create, and we can do a fusion. If we do an alteration, the key points of that is that we're modifying something. What are we modifying? The normal anatomical structure of a body part. Okay, so we're going to change that anatomical structure of that body part, but we're not going to affect the function of the body part. So the body part is going to keep doing what it normally does. Okay, however, we're we're um, we're modifying it. We're going to do something to that to allow it to keep doing its function. Creating, well, this is pretty limited. So new genitalia would be in here. So we're making new genital structures that doesn't physically take the place of a body part. Okay, so if we, let's see, well, this is pretty classic now that we do um, gender changes. Also, it's used for limited corrective procedures in patients with congenital anomalies. So maybe we're doing something with a cleft palate. Congenital anomalies is your key here. Fusion. Now, with a fusion, that would be taking an articulating joint or body part and rendering it immobile. So we're fusing an ankle joint. We're fusing part of the spinal column, the vertebra. And that is it. We went through a lot, I know, but I want to change it up this time because, again, I know you have questions and everything. This is very intimidating. But we only have about 30, 31, one, right? And if you go in and you make notes there in your manual, that'll help you with testing. But the more you use this, it's so defined and your definitions are limited and exact that before you know it, as you get involved in this, you're not going to have any trouble. So smile, because coding is fun, guys, right? The fun has just begun with inpatient. All right. Thank you for joining me.